All right, today we're going to go inside the human body to witness one of the most sudden, most dramatic battles in all of medicine. We're talking about acute respiratory distress syndrome, or as you'll often hear it called, ARDS. So what happens when your own lungs, the very organs that are supposed to keep you alive, suddenly declare war on themselves? I know, it sounds like something straight out of a sci-fi movie, but for patients with ARDS, this is a terrifying reality. Okay, so what is this thing exactly? Well, to put it simply, ARDS is what happens when some kind of major insult to the body, we're talking about infection, for example, triggers this massive, completely out of control inflammatory response. It's like your immune system panics and unleashes a devastating friendly fire attack on your own lungs. So let's start at the beginning. How does this whole catastrophe even kick off? You know, the really scary part about ARDS is that it doesn't start with something rare or exotic. It often begins with something incredibly common. Get this, a staggering 85% of all ARDS cases are triggered by things you've definitely heard of. We're talking about sepsis, a really bad case of pneumonia, or something called aspiration. These are common, everyday problems in a hospital that can just suddenly explode into a full-blown life-or-death crisis. So, how do doctors on the front lines even know they're dealing with ARDS? Well, they use a really specific set of criteria called the Berlin definition. Think of it like a checklist. First off, the timing has to be right. It all has to kick off within 1 week of that first clinical problem. Next, they look at the chest x-ray, and what they see is a classic whiteout, which means the lungs are just flooded. They also have to make sure it's not being caused by heart failure. And finally, the big one, the patient's blood oxygen levels are dangerously, critically low. And this really shows you how they grade the severity. Doctors use a key measurement called the PF ratio. Now, it sounds complicated, but it's actually a pretty simple idea. It's a ratio that compares the amount of oxygen in the blood to the amount of oxygen the ventilator is pushing in. The lower that number, the worse the lungs are doing their job. And once you get down into that severe category, well, the lungs are barely working at all. Okay, so now let's zoom in. I mean, really zoom in. We're going past the ICU room, past the ventilator, right down to the microscopic level, inside the tiny little air sacs of the lungs. We're talking about the alveoli. This is where the real war is being fought. This battle unfolds in 3 main phases, and they can often overlap. You can think of it like this. First, there's a violent flood. Then, the body desperately tries to repair the damage. And finally, for some, the battle ends with permanent, irreversible scarring. Let's really dig into that first phase, the exudative phase. This is the initial, catastrophic flood. Your body's own immune cells just go haywire. They become hyperactivated and start attacking the delicate lining of the lungs. That crucial barrier between the air sacs and the blood vessels, it just breaks down. And protein-rich fluid comes pouring into the air sacs. The floodgates are officially open. And the result? It's just devastating. The lungs literally begin to flood from the inside out. The very structures designed for breathing are now drowning, making it absolutely impossible to get oxygen without life support. Which, of course, brings us right back to the ICU. So when you're faced with this level of internal chaos, how do you fight back? What's the plan? Well, it's not guesswork. The medical team has a very specific, evidence-based playbook for this exact situation. And really, it all comes down to this one critical question. How do you help a lung that is mostly collapsed or just completely flooded with fluid? I mean, think about it. How do you manage that? The answer, it turns out, is this absolutely brilliant concept called the baby lung. See, doctors had this huge realization. In ARDS, you're not actually ventilating a full-sized adult lung anymore. Most of it is useless. You're really only working with a small, healthier fraction that's still functioning. It's like there's a tiny baby's lung sitting inside the adult's chest. And that one idea, it changed everything about how ARDS is treated. And this baby lung idea created a massive dilemma. See, the old way of doing things was just to crank up the ventilator and force those lungs open. But now they realized if you shove a normal, adult-sized breath into that tiny baby lung, you're just going to overstretch it, injure it, and make everything worse. So the whole strategy had to flip. It wasn't about forcing the lung open anymore. It was about protecting the small, fragile part that was still working. And this right here is the absolute core strategy. It's this incredible idea of doing less to do more. It sounds totally counterintuitive, right? But it's what saves lives. It really boils down to 2 simple rules. Number 1, Use low tidal volumes. That just means smaller, gentler breaths. And number 2, limit the pressure in the airway to keep that baby lung from getting overstretched and damaged. It's all about being gentle and giving the lungs a fighting chance to heal on their own. There's another amazing life-saving strategy that's, well, it's surprisingly low-tech but incredibly intensive. For patients with severe ARDS, the team will often flip them onto their stomachs, a technique called proning, for 16 hours a day, sometimes even more. Just that simple change of position uses gravity to help open up different parts of the lung, and it can have a dramatic effect on oxygen level. But here's the thing, winning that battle in the ICU, that's really only half the story. For the people who survive ARDS, and thankfully with these strategies more and more people do, the fight is often just beginning. You see, many survivors face this long-term condition called post-intensive care syndrome, or PICS for short. And it's basically this collection of really challenging long-term problems that can follow them for months or even years after they've been discharged. And the really tough part is that the wounds from PICS are often invisible. We're talking about really serious neuromuscular weakness from just lying in a bed for so long. There's also cognitive impairment, things like brain fog, memory problems, trouble focusing, and on top of all that, there's often a huge psychiatric toll, anxiety, depression, and even PTSD from the trauma of it all. And the impact on people's actual lives is just staggering. Just chew on this number for a second. 44%. That's the percentage of previously employed ARDS survivors who are still jobless 1 year after getting sick. The combined physical, mental, and emotional weight of PICS just makes getting back to a normal life incredibly, incredibly hard. You know, there's this quote that really hits home. Critical illness does not end with discharge from the ICU. In fact, some unfortunate patients never fully recover. It just perfectly captures it, right? The fight doesn't stop when you leave the hospital. For so many, the scars from that battle within, they last a lifetime. And so that leaves us with this big, important question for the future. We are getting so much better at saving lives from ARDS. The science is incredible. But the next great challenge is, how do we get better at saving the life that comes after? How do we not just help people survive, but help them truly live again?